Good evening. I'm Daneil Kuftinec, and I appreciate the opportunity to present today about PSMA PET imaging for prostate cancer. Just a little bit of housekeeping. This presentation does not contain medical advice, and remember to always talk with your doctor regarding medical questions that you have. By way of background, I'm a trained urologist, and I practiced clinically for nearly 15 years. Currently, I'm serving as Medical Director of Global Medical Affairs at Lantheus, where our corporate mission is to find, fight, and follow diseases such as prostate cancer. And at Lantheus, we believe that better insights mean better decision-making, and I believe that this can ultimately improve patient outcomes. Prostate cancer is the second most common cancer in American men, and about 1 in 8 men will be diagnosed with prostate cancer during his lifetime. Prostate cancer is also the second leading cause of death in American men, behind only lung cancer. So prostate cancer can be a serious disease, but most men diagnosed with prostate cancer do not die from it. In fact, more than 3.1 million men in the United States who have been diagnosed with prostate cancer at some point are still alive today. That's because many prostate cancers grow slowly and are confined to the prostate gland, where they might not cause serious harm. However, other types of prostate cancer can be aggressive and spread quickly. And that's why it's so important to understand the tests, one, used to diagnose prostate cancer, and to know your risk if you've been diagnosed with prostate cancer, and how imaging options such as PSMA PET can provide a more detailed picture of the extent of your cancer and your risk. Screening tests can help find prostate cancer at an early stage before symptoms appear. And 2 tests that we commonly use to screen for prostate cancer are prostate-specific antigen, or PSA, and a digital rectal exam, or DRE. PSA is a protein that's made by your prostate, and a high level of PSA in your blood may mean that you have prostate cancer, but it's not proof of cancer. That's because many other things can cause a high PSA. In general, however, the higher your PSA, the more likely it is that you have prostate cancer. The digital rectal exam, or DRE, is an exam of the prostate that checks for irregular or suspicious areas that could be a sign of prostate cancer. So PSA and DRE only tell you that you might have cancer. They don't actually diagnose cancer. Prostate cancer is diagnosed by obtaining tissue from the prostate, and this is typically done in a urologist's office in the form of a prostate biopsy. The tissue from the prostate biopsy is sent to be examined by a pathologist to determine if there are prostate cancer cells present. If you're diagnosed with prostate cancer, the tumor will be assigned a Gleason score or a grade group, and this number describes how aggressive the prostate cancer seems to be. The higher the Gleason score or grade group, the more likely the cancer is to be aggressive, meaning the more likely it is to grow and spread. Information about the cancer, including your T stage, your DRE, your PSA test, and other factors can help determine your risk group. The other factors that we include here are your age and your family history of prostate cancer or other cancers. Currently, patients that are placed in the intermediate, unfavorable, high risk, and very high risk for prostate cancer are candidates for further diagnostic imaging. Diagnostic imaging may help gain a more detailed picture of the extent of the cancer and your risk by giving a sense as to where the cancer is and how many tumors there are to make sure you get the right treatment. And as I mentioned on the previous slide, diagnostic imaging is often considered for patients with intermediate, unfavorable, high risk, and very high risk prostate cancer. So some of the common diagnostic tools that we have for imaging include what we would call conventional imaging, and that could be bone scans, computed tomography or CT, or magnetic resonance imaging or MRI. Just to briefly go over these types of imaging, computed tomography or CT uses X-rays to take pictures inside the body with a computer. It combines the pictures into a single detailed image of where the cancer may have spread or where it could be located. Magnetic resonance imaging, or MRI, is similar to CT, but it uses strong magnets to take pictures instead of X-rays. Both CT and MR are useful for seeing cancer in soft tissue within the prostate and areas near the prostate. Bone scans work with an injection called a tracer, which binds to cancer cells in bones and highlights them. Bone scans, however, do not see tumors in soft tissue. Positron emission tomography, or PET, also works with a tracer that highlights cancer cells in soft tissues and bones, making it easier to see where cancer is located and what parts of the body it has spread to. PSMA PET scans use a tracer that targets prostate-specific membrane antigen, or PSMA, which is overexpressed by prostate cancer cells. And where standard imaging or conventional imaging may have limitations, PSMA-targeted PET imaging has been shown to provide more accurate information. So here's a comparison of the different imaging options: PSMA PET, CT, MRI, and bone scan. And what I'd like to highlight is that PSMA PET can detect cancer in bone and soft tissue, whereas bone scans can only detect cancer in bones and not in soft tissue. Furthermore, PSMA PET CT can detect smaller soft tissue tumors than CT or MRI, and PSMA PET CT can detect tumors when PSA levels are low. And this is important for patients undergoing staging prior to definitive treatment who are suspected to have metastatic disease, and also in patients with a history of prostate cancer who are suspected to have a recurrence of disease, because improved diagnostic accuracy in detecting disease extent can lead to better therapeutic decision-making. So, as I reviewed some of the prostate cancer statistics a few slides ago, in addition to the incidence of prostate cancer and the mortality rates, we also know that there is a 5-year relative survival rate of 98%. However, treatment intended to cure prostate cancer, either with surgery or radiation, can fail, and up to 50% of men experience disease recurrence, meaning the cancer comes back. In prostate cancer, recurrent disease is often diagnosed because PSA levels begin to rise. In order to confirm recurrence, patients may have other tests, including imaging or biopsies. And in patients who have a rise in PSA after treatment for prostate cancer, PSMA imaging can provide critical information about recurrent disease distribution, both in soft tissue and in bone, in smaller tissues and smaller tumors, and at lower PSA values than conventional or standard imaging, allowing, again, improved patient outcomes perhaps and earlier treatment. This slide shows the most common sites of prostate cancer spread or metastasis. Unfortunately, some men already have metastatic disease at the time of initial diagnosis. And as mentioned on the last slide, some men develop metastatic disease after treatment that was intended to cure. And what I'd like to point out is that regional metastases happen when the cancer spreads outside the prostate, but within the pelvic area. Distant metastases is when prostate cancer spreads outside of the pelvic area to sites distant, such as bones or lymph nodes that are outside of the pelvis again. Treatment of metastatic disease depends on an accurate assessment of the sites and extent of tumor. So what exactly is PSMA, or prostate-specific membrane antigen? Well, PSMA is a protein that is found inside normal prostate cancer cells. PSMA, however, exists on the outside of prostate cancer cells. And as you see in this image here, this is the cell surface here, and this large portion of PSMA exists on the outside of the cell. This would be a prostate cancer cell. So it makes it a reliable target for tracers that can bind to PSMA. It's also important to note that PSMA is overexpressed in primary and metastatic lesions. It does have some limited normal organ expression, which is important for the doctors who are reading or interpreting your scans to be aware of. PSA versus PSMA can be confusing. And as I mentioned before, PSA is used as a screening test for prostate cancer, and it can also be used for monitoring for return of prostate cancer after treatment. Both PSA and PSMA are made in the prostate, but PSA is released into the bloodstream, and circulating levels of PSA can be affected by factors such as exercise, infection, inflammation, prostate enlargement, or even intercourse within a few days of testing. PSMA is not released into the bloodstream, and it isn't impacted by these factors. Since PSMA is overexpressed and is on the outside of the prostate cancer cells, it can be considered a reliable target for detecting cancer. So how does PSMA PET-CT work? Well, PET, or positron emission tomography, computed tomography, is a type of diagnostic imaging that works with injection of a tracer into the bloodstream. In our case, the tracer is a material that tracks and binds to PSMA on the surface of prostate cancer cells. And when the tracer binds to PSMA, a tiny subatomic particle called a positron is released. When this positron collides with another subatomic particle called electron, energy in the form of a gamma wave is released, and that energy is actually imaged. PET systems have sensitive detector panels to capture the gamma ray emissions from inside the body, and then they use software to triangulate the source of emissions, creating 3D pictures of the tracer concentrations within the body. So let's take a look at a patient who was diagnosed with prostate cancer and was planning to have surgery. This was a 63-year-old male with a PSA of 7 and a Gleason score of 4 + 5 = 9 disease in 13 of 16 cores. He actually had a negative bone scan and CT scan. He did have an MRI, which showed some extracapsular extension of the prostate cancer, as well as some seminal vesicle invasion. So he's high risk for prostate cancer, but despite the advanced local disease, his CT and bone scans were totally negative for metastatic disease. This is his bone scan here, and you can see this is the front projection, this is the rear projection, and there are no spots that would be indicative of increased tracer uptake that would show us prostate cancer. This, however, is his PSMA scan. And this is what we call the MIP, or maximum intensity projection. And all these dots here throughout his axial skeleton, throughout his long bones, throughout his spine, throughout his soft tissue, those are all foci of prostate cancer that were detected with PSMA imaging. And on the far right here, these are actually what we call the fused CT axial images. And what you can see are the bright spots that light up are tumor lesions within, again, the spine and his ribs. And so in this case, the patient was upstaged from clinical M0 to M1 disease, and his treatment was changed from surgery to systemic therapy. And this can demonstrate the impact that PSMA PET scans can have on management or treatment recommendations for patients. And I'd like to just also share a case of a patient who is being evaluated for recurrent prostate cancer. And this patient is a 73-year-old male who was treated with surgery in 2005. His pathology from surgery was Gleason 3 + 4 = 7, or a grade group 2, and he had T2NOMO disease at that time. He went for many years having an undetectable PSA, but then in 2019, he had an increase in PSA to 0.8. He had conventional imaging with CT, MR, and bone scan, which were equivocal or really didn't show any impressive sites of cancer. However, he had a PSMA PET-CT, which showed this small foci of prostate cancer, which was in a perirectal lymph node. And again, this is the maximum intensity projection, both from the front, or the anterior, and the back, and the red arrows are showing this tiny dot here, which is the lymph node. These are the CT images. This is the CT, and this is the fused image. And again, this bright spot right here is the perirectal lymph node that was detected. And so the patient was, instead of treated with external beam radiation to the entire pelvis with a potential boost to the area where the prostate used to exist, called the prostatic fossa, he was treated with focal radiation, or SBRT, decreasing his dose of radiation overall, and he had an excellent PSA response. So to wrap things up, PSMA PET imaging can provide a more detailed picture of the extent of prostate cancer, and PSMA PET imaging should be considered as part of the initial workup an evaluation of men presenting with intermediate unfavorable, high risk, and very high risk prostate cancer prior to definitive therapy, as well as in men who have PSA elevation after failed therapy. And I hope that I showed that PSMA PET imaging can provide important information about prostate cancer distribution and extent. And with this information, hopefully we'll be able to make better, smarter decisions and treatment recommendations for patients. And although we don't have the data yet, I firmly believe that better treatment leads to better outcomes. Thank you. And that's a wrap.
No, that's really good, Daneil. Thanks. We have a couple of questions that I think we'd like to put in here. One is, what is your position? I mean, really, as a both a clinician and an expert in this field, what's your position on supporting earlier screening using PSMA PET and not waiting for just the high risk or the high to intermediate risk guys, and with an eye towards getting a better picture of the staging and trying to catch the disease at an earlier stage?
Well, it's interesting that you mentioned that. I think that there is interest in trying to shift some of our early detection to men with intermediate favorable, because as we know that if those men are treated with, say, surgery, 25% will have upstaging. So, can we capture that patient population that has intermediate favorable risk going into surgery, but comes out on the other end with a higher Gleason grade or a grade group with PSMA PET imaging? That would be an objective.
Okay. And yeah, go ahead, Tony.
Yeah, wouldn't that kind of help you with your treatment decision? Like if you're at that really intermediate place, Gleason 7, PSA of about 9 or 10, they stage you at stage 2. But then you make your decisions based off the bone scan and MRI. And what you've shown here is that they may not necessarily show metastatic disease. So wouldn't a PSMA during that time help you to make better decisions about your treatment?
Yeah. So the patient that you're describing is sort of your classic intermediate unfavorable patient, where we do feel that PSMA PET CT has or MRI has better accuracy to diagnose either locally advanced nodal disease or metastatic disease. And so, the necessity to have conventional imaging with CT or bone scan, even according to the guidelines, we're shifting away from having those, needing those prerequisite scans of conventional imaging prior to having PSMA PET.
So Tony, just a couple of things. Number one is for your audience, I think it's very, very important that they understand that intermediate risk is broken into 2 factions or 2 sets. It's all Gleason 7, but 3 plus 4 is very different than 4 plus 3. Okay. Again, where the first number is the dominant pattern. Okay. So it's very different if you have a lot of 3 and a little bit of 4 than if you have a lot of 4 and a little bit of 3.
Okay.
And just to recap, also another place where we could see, when you were talking, Mike, about, using it earlier in staging in lower risk populations, there might be a role when you're trying to determine active surveillance versus treatment, or even in treatment planning for focal therapy.
Okay. I mean, I know there used to be the debate years ago about this M0, right? I mean, it's that you had your PSA rising, but you couldn't find anything on any of the conventional imaging, right? But then where do you list yourself? I mean, if your PSA is going, and I mean, we've seen cases where you've got 3+4 or 3+3, right? Guys on active surveillance or PSA is rising, but they can't see anything on conventional imaging, right? So that's to me, would you not agree that's a good spot for the application of a PSMA scan?
So that would be actually essentially considered an on-label scan because you've had treatment and now your PSA is coming back. And, one of the key takeaways for PSMA imaging, at which Daneil mentioned, is that typically, until we had PSMA, a guy would come in with a PSA of 0.2 or 0.5 or even 1.0, and we do conventional imaging, it would always be negative. And then we would just essentially, what we call empirically, give him radiation, because we thought that, most likely it's coming back from the pelvis where the prostate was taken out. Now we have a test, and in the Condor trial, these are all men who had recurrent prostate cancer based on the fact that their PSA was coming back. And they all had bone scan and they all had CT scans that were negative. And in that population, 60% of the patients had an identified lesion with PYLARIFY scanning.
Wow.
So the other, Mike, the other thing is you mentioned the terminology M0. So M0 means no metastatic disease by conventional imaging. And in what's called the M0 castrate resistance space, which is where the disease is, progressing despite the fact that you've been on hormonal therapy, and it seems that the hormonal therapy has failed, we now have pretty good evidence that that M0 state probably doesn't exist, because with more sensitive imaging, you find the disease in well over 90% of those men.
Yeah. And that brings up a question about the precision of these things. Does it matter the machine that's doing the PET CT scanning? Is there a specific machine that is like the model number that you should have, or are there better machines over worse machines? Should you have better software, or are we at version 1.0 or are we at version 5, or what does that do? And then, is there a limit to the type of machine that you got to use? And does it matter?
So I can send you an email with the recommended machines. There's a little list of them, but the basic answer is the older PET scans are called analog PET scans. The newer PET scans are all digital. You should always have a digital PET scan.
Okay. The other is, if you can review, you said normal expression, like when you do an imaging, Daneil, is that where you see like the big blobs, like is that in your bladder and in your salivary glands and that kind of stuff?
The so-called panda face. So there's normal limited tissue uptake. So it's in the lacrimal glands, behind the eyes, in the submandibular glands, the parotid glands. So that gives that sort of typical panda face. We see uptake in the liver, in the small bowel, in the spleen, and then there's also obviously kidneys, and then in the bladder where it's excreted.
Yeah, but that's not showing. That's just normal. That's not showing any cancerous tissue.
Does not show any cancer. I can, if you want, I can get back to that slide where we have a. Here you go. So this is the MIP projection. So this is that panda face here. So the lacrimal, the parotids, the submandibular, here's the liver, here's the spleen, here's the small bowel. In this case, these are the kidneys on either side. Here's the bladder, and we're actually seeing some tracer here going down the right ureter.
Okay.
And that's all totally normal.
Okay, that's great. That's great. And then lastly, my last question was, we're hearing this term and patients are asking around this term of theranostics. What is theranostics as it applies to this imaging and PSMAs and that sort of thing?
Sure. So theranostics in its sort of pure sense is when you have a diagnostic and a therapeutic agent that are one and the same. Currently, for prostate cancer, we have radioligand therapy for treatment. And that would be the lutetium-177 Pluvicto. We don't, for prostate cancer, as of yet, have any true theranostics. So we have diagnostic imaging agents, and then we have the radioligand therapy.
Okay, so that it's not, the Pluvicto is not theranostics. Is that correct?
Technically, it's not. Technically, it's radioligand therapy.
Okay. Okay, we're trying to get clarity here because
Yeah.
we're starting to get some of these questions, people seeing things in the industry or in advertising. So we just want to be clear on
Sure.
any of the messaging that it's going out.
And a lot of it can be semantics. And so, like I said, it's really in its very pure sense, theranostic means it's a combined therapeutic and diagnostic agent. Technically, we don't have any of those agents that are FDA approved for that right now.
And so, is there future work happening there?
Yeah. So Mike, I just want to clarify one thing, as Daneil said, technically it means this kind of combined agent that you can image and treat with. However, if you go to many other universities are developing or building out what are called theranostic centers, okay? And these would be radioligand targeted therapies for neuroendocrine cancer, prostate cancer, breast cancer, melanoma, and some of these other cancers. So I think that the term is loosely used to describe this, what we call targeted radioligand therapy.
This is great. And Bela, that's one of our core tenets at VPCa, is to try to educate our patient populations. And there's a lot of confusion with these new technologies and these new treatments that are coming along. So this goes a long way to clearing the air on those things and giving people proper definitions about what we're trying to do. That's great. Bill, questions?
Yes, I do. I have a question about the PSMA PET CT scan. How often should that take place after one has found some oleometastatic spots, or maybe 1 or 2 spots that have been taken care of with radiation, and follow up after that?
It's a great question, and I don't have a specific answer because we don't know. That's an active area of research, is to try to understand how we can utilize PSMA PET imaging in monitoring disease, either disease treatment and cure, or disease progression, or disease stability. So we don't really know, what is the sweet spot, or what is the effectiveness for, monitoring patients along that. Sometimes it's being used, and this is off-label use, but it would be, if you have a change in your treatment. So if you have a PSMA scan and you have, say, oligometastatic disease, and then you have treatment of that with radiation, say that patient that I presented with SBRT, that patient could be monitored with a repeat PSMA PET CT to see if that spot has resolved or has it decreased in size. It could be used again, and this would be an on-label use if you're monitoring a patient with PSA after treatment, and then the PSA goes up. Then you could, use a PSMA PET imaging to determine if the disease is, recurrent. Where is it? What's the extent? But we really don't have any discrete answers as to how often and exactly when, other than if you have a rise in PSA.
So the rise in PSA and perhaps a rise in testosterone, which they constantly check quarterly, I think, and if there's any change in that, delta that, then it would be suggested to do a PSMA PET CT again to see if things have gotten worse, spread or whatever? Is that,
Certainly with the rise in PSA, again, it would be an off-label use if it was just a rise in testosterone that you were seeing.
okay, because I'm in the middle of this whole situation.
Yeah.
And following it very carefully, as you
Yeah.
see.
So if you're, so Bill, if your PSA is going up and your testosterone's going up, you're not getting adequate hormonal suppression. So the first thing to do then would be to either change the ADT that you're on or add an additional drug to it, okay?
They've stopped that. They've stopped any of the hormonal treatment. So right now,
so you're on intermittent therapy then?
I'm just looking at that and an occasional bone scan for osteopenia or osteoporosis. But
Yeah.
that and the PSA stuff, that's all that they're doing right now.
So, you know, the only area right now where most centers are checking a follow-up PSMA scan is in patients who are getting lutetium or Pluvicto. So what's typically being done in patients, and these are patients with very, very advanced disease who exhausted all other options, okay, is that the current recommended course of Pluvicto or lutetium-177 is 6 courses over and 1 course every 6 weeks, okay? So if you're, you know, and it's expensive, it's, you know, full courses are around $260,000. So if you see a patient and you give them the first course, and then 6 weeks later, the second course, and then when they're coming in for the third course, if that PSA is going up, then a lot of centers will do a PSMA scan. And if it shows that the disease is not responding to the lutetium, then they'll stop. And the flip side of that is that if patients who have received 1 or 2 or maybe 3 courses of lutetium and their PSA has gone down to 0 or very low levels, then they'll do a PSMA scan. And if that scan's clear, then they'll stop, not to give them the additional 3 doses until it's needed later. So, but these are areas that are not well defined. They're too new right now.
Yeah.
So we're learning as you're learning.
Yeah. And Bill, in my case, I had both on-label and off-label scans done for mine. And I think I went to the most aggressive PSMA issuers on the planet. But anyway, so they did a scan prior, or I had a rise in PSA. They did a scan. They found a lymph node that was involved, presacral lymph node. It was SBRT and went for 2 years. And then PSA was responded, you know, down to, you know, below 1. And then they did another PSMA because my PSA was rising again. And lo and behold, they found a bit of a lesion on the top of my prostate, the apex of my prostate, that had never been seen before. And it had been previously treated, radiated, and the sacral, or the, you know, just a full treatment of taking all that stuff out. So it came back in the same place where it had been previously treated. So then we did a biopsy. Sure enough, Gleason 8 on the biopsy, but it was too small to operate on or to take to do radiation on, to do an SBRT on. So I had to do a laser ablation of that spot. Dr. John Feller decided they could take it out, so they did it. And then then I did a full course of radiation, pelvic IMRT, and then 2 more SBRTs on 2 other lymph nodes that they had found with the PSMA. Then I did a PSMA before they did, or it was after the laser ablation, before the radiation, and then I had another one after the radiation, so that they were just kind of trying to see what all they had done in there. And so, yeah, I think that there's also an application, in my case, especially for looking at taking a look to see if it's all gone, right? I mean, let's see what happens. I mean, you never know what surprise you might find in there. So, yeah, I think this is on the cutting edge. I think there's a lot of experimentation, and if you have an aggressive doctor, or if you need one, I'll give you a referral to a guy. And but yeah, it's an incredible technology. Tony, any questions?
I think I
No?
got my answer.
What I did find, excuse me.
Yeah, go ahead.
What I did find is what they did find was the one lesion on my hip, acebutulum. Maybe my pronunciation's off a little bit. It was small. They did a biopsy of it, and then they did the radiation, and following that, the hormonal treatment until that all ran out, and then just checking on me with the blood test for the PSA and the testosterone, and then an occasional bone scan and
Bone density. It's a bone density.
bone
Yeah.
density. Well, one full body bone scan, and then a bunch of bone density scans. And so it's a matter of, if there's a change, then they're probably going to go with another PSMA PET to find out if there's any further metastasis.
Yeah.
Basically,
That's great.
where I'm
And
at.
where are you getting? Who's doing the care, Bill? Where are you getting it?
Sloan Kettering.
Okay.
Sloan
Okay.
Kettering in New York. Actually, it's
Yeah.
here in New Jersey.
I understand they're pretty good.
Yeah. I think you're right.
Yeah.
Because
Yeah.
I think I had the PSMA PET scan 3 or 4 years ago.
Yeah. So
Well, that's great. I guess, Bella, any other like closing comments? Because I think this is going to be incredibly valuable as we push it out to, you know, our followers of 20,000 email links. I think it's going to set the world straight on what we're doing or what's available inside the VAs. I know there's still VAs out there that can't get access to PSMAs. We're still hearing that. We're available to try to move people. We have done that in the past. Our organization, if anybody wants to call in, we have thrown their credit cards down and moved them to places where they can get PSMAs. It's an easy process inside the VA to do a distant referral. The guys at West LA are always accepting them. You know, you just have to sign up for Berangi's trial and become a Berangi guinea pig. But other than that, it's great. I mean, and I think it's exciting technology. It's exciting what's happening. And, you know, thank you to Lantheus for all your support. It's really appreciated.
Is there a connection with the Million Vet research project?
No, there's not. That's a great idea though, Bill. I mean, a question for you, Bella, is there, or Daneil, is there research going on to look at all the way back at using some data from PSMAs or the AI type of stuff to look at people that are responsive because of what they're finding in their genes, doing the gene sequencing and that kind of thing?
So,
Or are you looking at, the other question would be, is are you looking at you know, this 10 or 15% of people that claim that they're not responsive to PSMA, and is there a gene correlation with that?
So, I mean, we're not doing that, but certainly in patients with advanced disease who have what are called discordant lesions, some lesions that pick up PSMA and some that don't, where you suspect that they have this so-called small cell or neuroendocrine differentiated cancer, those men all go for genetic testing, looking for these BRCA mutations and all these, all these other mutations, which may be inherited, may be somatic. We don't know. But, and part of the reason for looking for those mutations is there's a whole class of drugs called PARP inhibitors, which work very well in those patients, much better than hormone therapy.
Yeah, right.
So again, it's just part of that journey towards precision medicine. And, precision medicine is, people have asked me, well, what's precision medicine? That's simple. It's giving the right treatment to the right patient at the right time. And I think PSMA will help us get there.
Yeah, no, it's a key indicator. Yeah, it's absolutely spot on. Yeah.
Yeah, I'm thankful that this technology exists. A lot of the people that I deal with in my support groups and men at different stages didn't know anything about a PSMA, didn't know to ask for it or anything like that. So the group that we have, the veterans support groups that we have, they need this kind of information because they're lost. They need to know that these are some questions that you need to ask your provider.
Yeah.
You know.
Yeah. And I think that, the providers, I know that when we spoke at SGSUs, some of them are frustrated inside the VAs that they can't get access to these things. But we're big proponents then of making sure that there's clinics or distribution centers or guys that can do this in the community, and we sign up those people in the community so that they can actually receive the scan, receive the imaging, right?
Yeah.